Hiya. So I'm Hannah and I work in University Hospitals Plymouth. I'm currently working as information business partner for urgent and emergency care, but that just basically means I do a lot with urgent and emergency care data. So uh, my project, if it'll let me go forward a slide, there we go. My project has been based off sort of struggles with getting NHS care in a timely manner. So you've probably seen a lot of headlines that look like this. We've got the top set looking at waiting lists being record highs, and the bottom two looking at sort of long times in A&E and also long waits for ambulances. So there's a bit of a theme here. Everything is looking at getting into care, and there's not much detail of sort of what happens in um, in hospitals or on the way out of hospitals. So uh, this picture here is a really good way of depicting flow into and out of hospital. And this I've kind of shamelessly stolen from the IPACS project, which is improving patient flow between acute, community, and social care. And you can find that if you search GitHub for IPACS, and you can find all the code there. And this model forms the basis of my model and my project. So a big thank you to Alison Harper from Pencord, who helped me out starting up my project. So if we look at this flowchart, we've got non-elective patient admissions. So those are emergency admissions who come into hospital, and they can either have the treatment they need and then be discharged straight home, and that's what we call a simple discharge, or they might need a bit more care after hospital. So they won't necessarily need to have that care in hospital. Maybe they can go home and have some kind of daily visits, or maybe they can have bedded care. So that can either be in a kind of a short-term facility where they can go, and that's what we call pathway 2. If it's short-term, they can go and get kind of maybe reablement in a community hospital or something along those lines. And then pathway 3 being kind of more long-term bedded care, so things like care homes. So unfortunately, we don't have an infinite capacity of complex discharge placements. So if a patient has ended their kind of the treatment they need in hospital, but there isn't anywhere for them to go next, they end up waiting in a hospital bed. And in December of 2022, there's a statistic that 13% of all acute hospital beds in England were filled with patients who were clinically ready to move on to kind of the next part of their treatment, but couldn't go anywhere else, so they were waiting in hospital. So that's quite a big chunk of a hospital's bed base. So my project aimed to take this kind of previous model, IPACS, and add on ED, so the emergency department, and also elective inpatient waiting lists. So people who are waiting for some kind of usually surgical care on a waiting list. It's not an emergency, but it's something that needs to happen. And this was to understand if the delays in getting patients out onto onward care placements is affecting waits in ED and lengthening waiting lists, and how it is affecting them. So this would also be useful to assist with planning. So if we can say to maybe the local area, we need this many beds of this type to kind of facilitate flow through the hospital, we can help to lobby to get those bed placements. And also it was ideally going to help with operational decisions too, of how we kind of structure our care. And one of the other things that I was hoping to do with this project was to be able to create a model that anyone can use. I didn't want people to have to, if they wanted to use the model, to have to go and download Python or R, never having used it before, and then have complex ways of inputting it, not knowing how to run it, and having that big kind of barrier to getting set up. So that was one of the main aims going throughout the project as well. So I use discrete event simulation, and I'm sure you've heard a lot about discrete event simulation today. But the reason I picked it for this project is to be able to have that kind of randomness and variability in processes within this flowchart here. So patients flow through this flowchart. There's different ways in and different ways out, but doing it with discrete event simulation means that we don't have to say, for example, it takes half an hour to see a doctor every single time. We can say there's a distribution of times it takes to see a doctor. It's probably between 15 and 45 minutes, and the most likely time is around half an hour. But having that variability means that you can model actual sort of real situations a bit better. You can say, actually, this patient was really complex and it took me a bit longer, or this patient was really easy and it only took 10 minutes. And then building all those different permutations of different numbers of people arriving, different times for each person going through the pathway, builds you up sort of good days of performance, bad days of performance, and everything in between. And then we can take an average and get a bit more of an idea of what the performance might actually look like. So that's why I use discrete event simulation. And in this flowchart here, we've got sort of the bottom half, which is basically what we saw in that IPACS flowchart before. And then we've got the bits that I've added on the top here. So the bit in red is ED, so ambulance arrivals, walk-in, and then patients can get discharged straight away from ED and get sent home, or they need to be admitted into the hospital. And then we've got patients who are waiting on an elective inpatient waiting list who can then get admitted into the hospital and treated. And then this is very similar to what we had before. So they are either a complex discharge, in which case they need a spell at a complex discharge location, or they're a simple discharge and they're just discharged straight away from the hospital. So although this simulation runs at a patient level, all of the inputs and the outputs are aggregate. And what that means is basically you need kind of total number of arrivals to ED in a day, or average additions to the elective waiting list per day, rather than trying to say things at a patient level, because that should then make it easier for different kind of sites and trusts to be able to put their numbers into the model. So the outputs, the main outputs here are sort of occupancy in each area over time. So looking at how many people have we got in ED, how many people are waiting on the waiting list, is the hospital full, and are our complex discharge locations full? And we can also break it down by the number of patients ready to be discharged in hospital at any one point and what they're waiting for, as well as seeing the patients, which was kind of the main aim of this project, is seeing the patients in ED and on an elective waiting list. So I'm going to try to bring up my Streamlit model, and hopefully you can see that now, but shout if you can still see PowerPoint. So along the left-hand side here, we've got input parameters. So I'm sure you've seen a couple of Streamlit dashboards today. So you can just click and drag and move these numbers around to be looking at a different input data set and press run the simulation. And then you can see that you've got occupancy over time for each of the areas, percentage occupancy, and the scenario that I've run is pretty full all the time. And then we've also got queues. So this light pink is sort of people waiting to get into the hospital, so either on an elective waiting list or in ED. And you can see that that's decreasing over time with this scenario, but actually we're starting to increase our queues for pathways 1, 2, and 3 at the end of the month. So I've only run this for 30 days. And this isn't quite ready to be live yet. So there's quite a few changes I'd like to make to this, but eventually it'd be great to have this somewhere where people can go access it and put in their numbers that are kind of guesstimates or values for their trust or facility, and see how it affects their numbers. So I'm just going to click through those slides. Yeah, so in conclusion, I've built a model that is hopefully easy to run and generic enough that different sites can use it and take a look at it and say, actually, in order for us to have good flow in the hospital, we need a lot more pathway 2 beds, or we've actually got too many of this kind of pathway beds. Can we move them to a different pathway? And future work, I need to do some more validation. So I'm hoping to get kind of a week's worth of data that is real hospital performance for my trust, and then have those inputs go into the model and see how the outputs of the model compare to what actually happened. Dashboard tweaks, I want to I can definitely make it a bit prettier and definitely add a few other things in there. And then some more feedback from stakeholders, at which point we'll hopefully kind of have some more discussions about how this can be used for planning and operational decisions. And then just quickly to kind of end on my experience of HSMA5 so far has been great. I've really enjoyed it. I came into this with a little bit of coding knowledge. I'd done some Python before, but it's been so useful to have the kind of massive breadth of knowledge. So there've been so many things covered, and I now have resources in terms of the YouTube videos as well as the slides and kind of small bits of code that we've worked on and that also have been supplied throughout HSMA5 to go back to. So if I start a new project now and it is something that I've not really looked at before, I will quite often go back to those resources and kind of double check what the best practices are and things like that. And that has been so useful. Yeah, and that's the end. If anyone has any questions, let me know. My email's there if anyone wants to get in contact about the code or the Streamlit app. And I mean, also a shameless plug if I'm allowed. We've got a new job opportunity coming up in the team. So yeah, keep an eye out on NHS jobs if you're on the lookout for a data science job.